Good evening, doctors and colleagues. I am Sharon van der Ross, and on behalf of Lancet Laboratories, I would like to welcome you to our inaugural live COVID-19 webinar. We appreciate your taking the time to participate in what we believe will be an informative and beneficial session. There will be access to a live Q&A throughout the proceedings, and we encourage you to forward any questions to our speakers who will attend to them in our post-presentation Q&A session. An email will also be shared with you afterwards to respond to any questions not answered during this evening's session due to possible time constraints. Without further ado, I'd like to introduce our first speaker of the evening, Professor Vardas, who's a clinical virologist at Lancet Laboratories. Over to you, Prof. Vardas.
Thanks very much, Sharon. I hope that my screen is sharing. Is it sharing yet? Can you see anything?
You're good to go, Prof.
Okay, excellent. Thanks very much, and thanks everyone for making time to come through tonight. Well, hopefully to your nice cozy place, and I hope you're not load shedding. So today we're going to have 3 talks. I'm not going to take up all the time with my talk, so I'll dive right in. COVID is a new virus, as we all know, and we've only known it really for 9 months, and so there've been a number of flip-flops on treatment, on the pathogenesis of the disease, about asymptomatic carriers. We thought it was unlikely, and then it was about 60% or more that we've established. Social distancing, the flip-flops on prohibitions, I'm not even going to touch. Those are inexplicable to anyone. I think Tanya's going to speak about children and going back to school and the flip-flops of do and don't. Convalescent plasma, is it good, is it bad? PCR testing guidelines have flopped all over the place. What sample to take? We've had test denialism and people not believing their results, a positive or negative result, whatever it may be. We've had our own more recent flip-flop of approval and then retraction of antibody tests in South Africa, and the flip-flops about vaccines being the only way out of this, and then people saying, oh no, they're not going to be all protective. You'll be pleased to know we're only going to deal with 3 of these tonight. A little bit on PCR testing, a little bit on antibody testing, and a little bit on vaccine testing. So this is an all too familiar picture to all of us. We have all looked at this map with horror and seen the dots increase on a daily basis, and this is from Monday, so I'm sure it's already out of date. But globally, we have 25 million infections, and South Africa has the dubious honor of being 6th in the world with the number of infections. So we are quite up there. We have over half a million cases, and we have managed to do about 3.5 million tests, which I think is quite remarkable. The good news is that, in fact, we have reached our peak and we seem to be coming down. And these are the number of cases in South Africa that have come down during August. And I think we've all realized that in our practices as the panic and the number of cases that we've seen has decreased. This is the coronavirus family picture. And the little, you don't need to remember anything about this, except that there are a whole bunch of them that each have their own characteristics, and the ones in red are the human coronaviruses. But much like this family portrait here, there is always the one baddie, the biker chick, or the bad virus, and I think SARS-CoV-2 has been the bad virus. If you compare the genetic materials of these viruses, and this is what this diagram down in the right bottom corner is doing. So they basically looked at the genetic material and stripped it all out and said, well, how do they compare? How does SARS-CoV-2 compare with the first SARS virus and the MERS viruses? And they are very similar, about 80% similarity. But the most similar, the SARS-CoV-2 is to the rat G13 bat virus, a 98% similarity, and hence you understand my biker analogy. So looking globally at all of the coronaviruses, they all seem to come from bats. They all have an intermediate host. We had camels for MERS, civet cats for SARS-CoV-1, and possibly the pangolin for SARS-CoV-2. There is transmission to humans through contact of mucus and fluids, either by diet or close contact. And now there's increasing data to show that there is transmission from human to domestic animals and farm animals. So we've had a number of papers being published now of transmission from a human host to cats, dogs, and to minks, farmed minks in China. It is important for us to realize what this virus looks like, and you're all probably bored of this coronavirus little crown thing, or of all the spikes sticking out of this virus. This is an electron micrograph of this virus with spike proteins forming the crown. But why it's important to understand what each of these proteins does in the structure of the virus is because we use the proteins for our diagnostic tests, and we use the proteins for making of the vaccines. And the first and probably the most important protein is this purple spike protein that forms the corona. The spike protein is the protein that actually attaches to the ACE receptors. It has a number of different conformational changes that causes fusion of the virus with the cell, with the ACE receptor, and has also got something called a receptor binding domain on it. So very important, because a lot of our diagnostic tests are targeted towards that, and a lot of our vaccines are also targeted towards that. Then we have the matrix protein, this green U-shaped thing here, which is embedded in the so-called envelope protein, this grey protein. And then the most abundant protein that we have in this virus is the nucleocapsid, or the N protein, which actually binds around the viral RNA. Very important for you to remember that it's the most abundant, and so it's the easiest to measure in an immunoassay when we come to the antibody testing. So that's the important thing here. It was very obvious quickly with SARS-CoV-2 that most cases were mild. We had a group of cases that were severe, that required hospitalization and oxygen, a group of individuals that were critical and who suffered extreme respiratory failure and multiple organ dysfunction, with a case fatality rate of about 2%. The big issue was, what was the difference that made so many people have mild disease? Was it because they had some sort of pre-existing immunity from other coronaviruses, exposure to those coronaviruses, or was it a genetic thing? Was it a human genetic protection, or was it because the virus was more virulent? And slowly it's coming to light that it is more a human immune system issue. It is not a viral system or viral difference or virulence difference, and it certainly is looking more as if we can put it to the immune system. The other thing that quickly became, unfortunately, an Achilles heel for us in all of our control strategies for this viral infection was that we realized that asymptomatic SARS-CoV-2 was very common. And we saw this in a number of different publications coming out quite early, and then various natural experiments that occurred in enclosed environments on ships, the Diamond Princess, and the Theodore Roosevelt. The big difference between the Diamond Princess and the Theodore Roosevelt was that the age of the populations on the Diamond Princess was slightly older, and the Theodore Roosevelt was slightly younger. The surprising thing that we discovered was that asymptomatic carriage was more common in younger individuals. And this was also then subsequently reflected in women being admitted to labor wards. Sorry, submitted, I suppose, is probably also also true. But it was quite a high percentage, and people were very surprised by that. But it does actually put a whole spanner in the works of how we managed this disease. This is an algorithm that was drawn up by the Colleges of Medicine of South Africa, the Public Health Task Team, and they tried to be logical about this and say, okay, we have various testing strategies and they have various purposes. If we look at screening, it's to identify those individuals that have SARS-CoV-2, and we will use symptom questionnaires to look at that. Once we have identified them based on their symptoms, we will test them to make a diagnosis, and we will use PCR for that. And then at a later stage, we will do surveillance to determine population prevalences using blood tests. The big issue was that symptom questionnaires were not sufficient. The symptoms were too nebulous and too generalized. And so what we had to do was actually combine our strategies of testing and screening. So what we did is we repurposed a diagnostic test to now use it as a screening test. And we duly did that throughout the world. And here is a chart that really shows you selected countries and the number of tests that were done over the few months or the first few months of this infection. And you can see that South Africa was quite up there with most of the other countries. Nothing like the US, but nothing like the infections that the US currently has. So if we examine this this test that we had to repurpose, this diagnostic test, you're all very familiar with it now. You're all very familiar with the sampling techniques, nasopharyngeal, and we've gone through a number of flip-flops on that, saying, okay, you can use oral pharyngeal, you can use nasal. No, nasopharyngeal is the best, and then we flipped back and forth on that. But anyway, a nasopharyngeal sample is the best sample if it's taken correctly and at the correct time. We identify the virus on the swab and it's taken to the labs where we do something called an RNA extraction. It is automated in most labs, but it can be done manually as well. And what you then do is that you isolate the viral RNA. Once you've got it, you have to transcribe it into DNA because DNA is easier to work with. And once you've done that, you need to amplify it. And this is where we start to select bits of the virus genetic material that we want to amplify. And that's going back to the structure of that virus that we looked at just now. We select different parts of the virus. Are we going to look at the N genes? Are we going to look at the E gene? Are we going to look at the R gene, etc., and combinations of those? And then we amplify them. The big problem was that at the very beginning, various genes had been selected by various manufacturers to have in their kits, and it was not consistent. Firstly, there was also an inconsistency of instructions from health agencies to say, well, what is a positive result? Initially, you had to have 2 genes, then it became 1 gene, and then it was very test manufacturer dependent because some manufacturers would only have 1 gene or 2 genes in their test. And at certain stages of our pandemic, we just couldn't access test reagents, so you were forced to just do whatever test you had. So there was this variability that was uncontrollable. The second sort of imperfect gold standard thing was that once you start to amplify the DNA, you have something called a cycle threshold or a CT value, which is an endpoint to the amount of virus that is present in the sample. And it is generally becomes a little bit dodgy at the upper end of the range. And this is because, and it's counterintuitive somewhat, at high viral loads, you have low CT values. So that guarantees that you've actually identified the virus. As the CT value becomes much higher, you have lower viral loads. And these can be so-called false positive results, where the viral load is actually very low, but it is detectable. Within a public health emergency, you cannot call those negative, and we were calling those positive. Whether they were false positives, we have yet to show that. So again, going to this imperfect gold standard that we had, this graph is actually a very nice graph which shows the so-called false negatives of these PCR tests. So even if you look at this red figure right in the middle of this diagram, this is a symptomatic individual at the peak of their viral load. You can have a 20% chance of having a negative result in spite of the fact that the person is infected. And so this is your false negativity rate of the PCR, and it's dependent on the test that you use, as well as the sample that you got and how the sample was taken. You can see from the figures at the bottom here that if you do a test immediately after exposure to a COVID positive patient, you will have a negative result because it takes a few days for infection to take place. And so as you go along, an infection and there's replication of the virus, you might be able to detect that virus. Much the same on the other side of the graph. After you having recovery, virus can be detected up to 21 days after infection. And so people are saying, well, you've got detectable virus, but is that infectious? And it's unlikely that it's infectious after the 14 days. So very mixed messages, and making this test really difficult. And I must say, everyone grappled with this at the beginning, but people have become experts on this. But the tests are also costly and they are technically difficult. And as you know, as the demand increased with the peak of the infections, our turnaround times became compromised. And that is a very big problem for a test that you need a quick turnaround time on. So people started to look for other types of tests. There are immunoassays that people looked at. There are antigens that you look at in respiratory samples, antibodies that you look at in blood, various antibody types, and lab-based tests or lateral point of flow finger prick tests. If we look at the dynamics of what happens with antibodies with SARS-CoV-2, there is a so-called window period where you have before detection of antibody from infection to the detection of antibody is about 14 to 21 days. And so that's been a big difficulty because you cannot use these antibody tests for acute diagnosis. However, IgM does occur at around day 7, as does IgG. The IgM diminishes quite quickly, but the IgG we think lasts for up to 3 months, 3 to 6 months at this point in time. However, this is again something that we're all learning about, and we are waiting to see how much longer antibodies and protective antibodies will last. Most of the tests that are being made at the moment include either spike protein for the immunoassays and nucleoprotein. And nucleoprotein, we said, is the most abundant protein. The spike protein is the most immunogenic protein. And so combinations of these are necessary, and combinations of IgG and IgM are currently the standard test that we want to use. I'm not going to spend much time on this, on the lateral flow point of care tests. As with all lateral flow tests, they are suboptimal in their specificity and they cannot be used for these so-called immunity passports. And I think that this was the biggest fear of SAPRA. These are the applications that we would like to consider for SARS-CoV-2 lab-based tests. For research, we want to use them for outbreak investigations, hotspot identification, and community surveillance, and of course, most importantly, for vaccine trial endpoints. We have proposed that they should be used for asymptomatic screening in employment, quarantine facility, and school screening, and this has been the most controversial, as well as healthcare worker screening in hospitals, and possibly also for pre-admission screening. If you have a positive antibody, that person is no longer infectious and has been infected in the past. We think that they have a role to play in clinical diagnosis for people that have clinical COVID but a negative RT-PCR, and we know that the RT-PCRs are not perfect. With discrepant RT-PCR results, a positive then a negative, and people don't know, you could use a tiebreaker test with an antibody, and then with certain syndromes like the multi-system inflammatory disease in children and encephalitis. So very quickly in the last few minutes, finding drugs and vaccines, you all are aware, go through various different preclinical tests. Then after animal studies, they enter humans in phase 1 and 2. And before they enter large efficacy trials or phase 3 trials, it takes about 5 to 15 years. And then the results of phase 3 trials are required for FDA review and confirmation of safety and efficacy. And then you carry on looking at them in phase 4 trials. So it's a very, very long process, which really has been repeated for everything, including Ebola. But we are now looking at pandemic speed, and what we have done and what is being done is that everything is being sort of concertinaed into a short space of time. Phase 1 and 2 trials started in July and have already been completed. Phase 3 trials are in progress right now. And so that's a very, very, very fast way of approaching these things. The array of vaccines available, there's about 130 different types of vaccines available, and they are really in 2 main groups, either gene-based or protein-based. The gene-based are looking at gene sequences that encode viral proteins, and those are introduced in some way into humans using either live vectors or recombinant vectors or nucleic acid vaccines, and this is the new thing here. The protein-based vaccines are the ones that we're very familiar with, the whole inactivated vaccines, viral-like particles like our HPV vaccines, and these are all manufactured in vitro. The phase 1 and 2 results have already come out of all of the most important vaccines, and they've been published, and they are relatively safe. So far, people have had to add Panado because people have side effects of a sore arm and a slight temperature, but those are not bad side effects. You've all heard of Operation Warp Speed, which is the 8 vaccine candidates that are being accelerated by the private-public partnership in the US. And this is the list of them. You will see that you have the Moderna, which is an mRNA, as is the Pfizer. The AstraZeneca is a chimpanzee adenovirus vaccine. That's your Oxford vaccine, which is in South Africa. The Novavax is a viral-like particle vaccine, which will also be done in South Africa, and that's a 2B trial. And then you have a whole variety of others. You have the Janssen adenovirus 26 vectored vaccine, the IRV vesicular stomatitis virus vectored vaccine, and the Vaxart oral vectored vaccine. So quite exciting. But also we forget that China has already 3 phase 3 trials. They're way ahead of us. And of course, the first registered vaccine was in Russia, which is the Sputnik 5, and that is an adenovirus 5 and an adenovirus 26 vectored vaccine. Sorry, that's telling me I'm out of time. I think this is the last slide, but the most important part of all vaccines is that it's a risk benefit, and we are giving a vaccine to people that are healthy, and it needs to balance out and be beneficial rather than any risks. And there's been a little bit of worry about SARS-CoV-2 vaccines to cause these antibody sort of mediated enhancement of disease, much like the dengue virus disease, as well as enhanced respiratory disease. But those are very complex mechanisms, and no one really has proven that these will occur yet. One other issue that needs to be quite clearly put up front is, well, even if we do have vaccines, are people going to take them? There's the study here of influenza vaccines in South Africa in the private sector, and only 15% of high-risk individuals were actually taking influenza vaccines. So it's a complicated and difficult thing for us to navigate, but we are hoping that this is not going to be a flip-flop and that the vaccines will be beneficial and will be useful to all of us. So I think that's the last slide. Thank you for the attention, and I'm sorry I had to rush the last few minutes. Thank you very much.
Thank you very much, Prof. For that. Just a reminder to all to please double click on the link in the Q&A session, where you'll be able to access your multiple choice questions, which will enable you to get your CPD points. Without further ado, I'd like to introduce our second speaker, Prof. Wright. Prof. Colin Wright is an anatomical and histopathologist at Lancet Laboratories. She will be talking to us this evening about COVID-19 and placental testing. Over to you, Prof. Wright.
Thank you. I'm just going to share my presentation. If you give me half a minute. Thank you. Okay. So when this virus came along initially, there were little concern, I think, in the obstetric and pediatric community about it, as we can see from this initial slide. Because in the first evidence was that there was very little evidence that there was vertical transmission to the neonate. And unlike H1N1, mothers did not appear to be significantly affected during their pregnancy. However, as time went on, there was a little more concern generated. This paper here looked at why initially there was no significant vertical transmission. And although the syncytial trophoblast, like the alveolar capillary barrier cells of the lung, has significant expression of ACE2, which reaches a peak in the 3rd trimester, it does not have a second cell membrane protein, caveolin-1, which is also involved in the internalization of viruses, and is also used for activation of leukocytes and initiates an inflammatory reaction. So even though it has ACE2, after caveolin-1, it's unable to allow this internalization of the coronavirus and activation of this inflammatory cascade. Also, there's no the deciduor cannot allow the virus to transmit through the deciduor in the 1st trimester, because the deciduor itself does not express ACE2 in the 1st trimester. As time went on, there was some concern that there are certain factors that may facilitate vertical transmission, such as a very high viral load, possibly multiple simultaneous pathogens, such as more than one virus, such as CMV and coronavirus, perhaps chorioamnionitis simultaneously with coronavirus, and then concurrent maternal systemic disease, such as hypertension and coronavirus, or perhaps an immunocompromised mother. And then, of course, the pathologists got involved and they started looking at the placentas. And there were very few still papers that were published looking at placentas of women with COVID-19. And it was found that even in mothers who were either asymptomatic or had mild symptoms, there certainly were pathological changes in those placentas, more than those of controls. And the changes that were identified were those of maternal vascular malperfusion, fetal vascular malperfusion, or thrombi in the placenta, a very odd pattern of inflammatory changes. Now, it was then suggested that possibly PCR on the placenta should be performed to confirm the presence of virus in the placenta. And in order to confirm then vertical transmission, it was suggested that PCR could also be done on the amniotic fluid, but this had to be done prior to membrane rupture and also on neonatal blood immediately after delivery. And that longitudinal follow-up on these neonates into childhood should be performed, because there's very little still known about the effects of this virus should there be neonatal transmission. Now, the histopathological changes that have been identified to date are, first of all, there may be no effect whatsoever on the placenta, even in mothers with quite severe disease. Secondly, maternal vascular malperfusion, and this very strange inflammatory pattern, which seems to be a combination of chronic velitis with massive perivillous deposition around these villi, associated with an infiltrate of histiocytes in the intervillous space. Thrombi in the placenta, and as we know, COVID is a thrombogenic virus, and then also an increase in cirrhosis, or an increase in the number of capillaries visible within the villi and intervillous thrombi. Here one can see an example which I've put on to demonstrate you, because you know how much pathologists love pictures of what they see. And these are little thrombi within the stem villi and within the lumen of the vessels here. This is, decidual arteriopathy or fibrinoid necrosis of the decidual vessels, which one would see in maternal vascular malperfusion. And this is the strange pattern that has been associated with the in COVID-19 mothers. And this is this massive infiltration of the placentas with clumping together of the villi with fibrin. Histiocytes, as one can, over here, in the intervillous space. Now, this can be extremely severe, and in the fetuses where stillbirth has occurred, about 80% of the placentas have been involved by this pattern. We can see here the sections taken of a placenta where this delicate lace-like pattern of fibrin is involving more than 80% of the placental parenchyma, which is incompatible with life. These are intervillous hematomas, which are large, and they are surrounded by infarction. And this is the pattern of chorangiosис, where in every villi, every villus, there are more than 10 little tiny capillaries visible. And this is not actually an increase in the number of capillaries, but dilatation of the network, which on cross-sectioning makes these capillaries more prominent. Now, the diagnostic modalities which can be used on placental tissue to demonstrate the presence of SARS-CoV-2 are, first of all, these morphological patterns which have been described. More accurately, PCR on paraffin-embedded tissue blocks. And this has been demonstrated to be is perfectly adequate. And in fact, this is preferred because if a portion of placental tissue is taken randomly, placenta is a very large organ, and it's like taking sort of a hit and miss if one just takes a small portion of tissue and submits that for PCR. Where if one is first looking at the placenta, one can take an area where there appears to be damage and submits that for RT-PCR. The chance of getting a positive result is much higher. Of course, in some of the papers that have been published, immunohistochemistry has been performed. We've tried unsuccessfully to get the larger companies that get our antibodies to import these antibodies, but as this, in their words, seems to be a transient disease, it doesn't appear to be worth their while to import these antibodies. Likewise for in situ hybridization, and electron microscopy is not used very much, but the viral particles can be demonstrated in the placental tissue. We can see here, this is electron microscopy from one of these papers showing the viral particles within the placental tissue, in this syncytial trophoblast. And here is very beautifully demonstrated from the same paper, the immunohistochemistry demonstrating the virus within the trophoblast and in situ hybridization. This is a meta-analysis on hospitalized women with all coronavirus spectrum infections, including MERS and SARS-CoV-2. They looked at 19 published studies in 41 pregnancies. And we can see here that this is not an insignificant virus when it comes to pregnancy and outcome. Mothers with COVID-19 disease had higher rates of preterm birth, preeclampsia, while babies had a 2.4 rate of stillbirth, 2.4% rate of neonatal death, and a much higher rate of admission to the neonatal ICU. So what is this mechanism of fetal injury and adverse outcome, which is, I think, reasonably significant? Well, one might think the virus could be transmitted to the placenta and thereby vertically transmitted to the fetus or neonate. However, the virus itself may be damaging the placenta, and by damaging the placenta, not necessarily being transmitted to the fetus, but in damaging the placenta, that damage in itself may have an adverse outcome on the fetus or neonate. The entities that have been described in themselves are poor prognostic entities. For example, chronic velitis, the significance of chronic velitis, particularly when high grade, it has a high perinatal mortality, increased neonatal ICU admissions, and significant neurological adverse sequelae. Chronic histiocytic intervillositis itself is associated with an overall perinatal mortality rate of 80%. when one has a significant amount of fibrin in the placenta, as I've shown you in the macroscopic picture, massive perivillous fibrin deposition, it is associated with a 40% rate of intrauterine fetal death, significant neurodisability, and 58% rate of preterm delivery. Fetal vascular malperfusion is associated with CNS injury, fetal stroke, intrauterine growth retardation, and intrauterine death. Now, all of those entities that have been demonstrated that are associated with COVID-19 have got a significant recurrent risk, some of them of up to 100%. Is this recurrent risk the same if it is associated with the virus as if it occurs de novo? We don't know. However, these are all questions that, with the large studies that are being performed at the moment, these answers hopefully will emerge with time. But in the meanwhile, there is, I think, sufficient reason to be concerned. And in patients where there is concern, I think that taking note of this virus, not treating it lightly, I think, is something that we should all perhaps treat with respect and take note. Thank you.
Thank you very much, Professor Wright, for that very, very informative presentation. We are aware that participants are unable to access the link for the CPD multiple choice questions. We will be sharing the link via email to all participants after this evening session. Our final speaker this evening is Dr. Tanya Dennis. Dr. Dennis is an executive member of the South African Pediatric Association, and she's in private practice as a pediatrician at Mediclinic Sandton. Dr. Dennis will be speaking about COVID-19 and kids going back into the classroom this evening. Over to you, Dr. Dennis.
Thanks, Sharon, and thanks to the Lancet team for the invitation to do this talk. I'm just trying to get it into, there we go, into a presenter view. So this topic of back to school has been covered quite extensively and debated quite hotly by various sectors of the community. But as pediatricians, we've always been quite united in wanting, just wanting one goal, and I'll take you through the evidence and the reasoning for that in the next few minutes. So let me just move on. Okay, so the discussion around children and COVID-19 has actually been, wow, it's really remarkable that children are so minimally affected. They either have a very mild disease or very often completely asymptomatic disease in the face of a positive PCR test. And so most of the time that's the discussion that we're having, but the impact is definitely there. And rather than being a medical disease or a medically affected, these children seem to be socially affected, and that's what we're talking about today. So the social impact is quite significant, and that's in what they've missed out on in these past few months, or the majority of children, in terms of their schooling. So just to go over quickly, why did the schools close in the first place? And it's been shown repeatedly that children frequently are the vectors of respiratory viruses. So you can see in that reference, and that's just one of many, that once schools open, it's quite common that the respiratory viruses start to peak, and people, not just children, but their families, the people in the household, become sick. And so it was a very reasonable consideration that this virus would be no different. And the action that was taken was swift and at the time appropriate. But over time, and with the countries that experienced their peaks prior to ours, they published their data, and it seemed that children were really not as affected. So firstly, they were less likely to contract the SARS-CoV-2 virus. They were less likely to transmit within their households. That they don't, and they don't contribute to the school outbreaks as we would have expected them to. And I'll go into a little bit of detail with this, children's risk for serious illness is extremely low. Towards the beginning of August, there was a lovely data analysis that was published by the NICD reporting on children less than 18 or 18 years and under in South Africa. So just to break down the numbers, in terms of cases, children only made up at that stage 7.4% of the COVID-19 cases in the country, despite making up 35% of the population. So in terms of absolute numbers, 33,000, just over 33,000 were children. And at that stage, 445,000 tests had been, or positive tests had come back. And interestingly, age, even within the pediatric age group, makes a big difference. Makes a big difference. So, and I'll show you that in a slide in a few minutes. In terms of admissions, children only made up 3.2% of the admissions through the country. So just over 1,000 out of 33,000 total admissions. And interestingly, children less than 1, despite being less affected, made up 25% of those admissions, and that probably speaks more to the pediatrician's paranoia about their younger patients rather than the level of illness in these patients. Interestingly, of those with known, there were 14% of those who had known comorbidities, and that also I'll speak to in a second. In terms of mortality, that minimal percentage of affected or of children who had passed away. Compared to the total, so only 0.004% of mortalities occurred in children, and the majority of those ones, or a significant proportion at least, occurred in children who had significant underlying comorbidities. So this graph, this is from the NICD report, which just shows that, and it shows you in terms of age group, the older age group has a higher cumulative incidence. Over there, that's the 15 to 18. The 10 to 14 year age group, slightly lower. The red dotted line is the cumulative, so all children under 18, and then lower and lower as they become younger and younger. So even as we're seeing children, as a group, we say children are less affected, even as the children get older, the risk becomes slightly higher. This one just speaks to the number of admissions in the positive cases. So it's slightly differently distributed. So this whole section over here is the under 1 year category, and the majority of admissions, as I said, well, a relatively higher percentage of children admitted were under 1 year when they tested positive, and that really does speak to probably a caution on the side of their managing doctors. And then this one just again speaks to cumulative incidence. So as the age group increase, so as the age increases, the higher rate of actual infections in those patients. The slide is a bit difficult to, well, just difficult to go through very quickly, but I wanted to highlight the comorbidities that a lot of these patients did have. So the children who are previously well and unaffected by any other diseases generally do extremely well. This speaks to which underlying illnesses the children who did contract SARS-CoV-2, the SARS-CoV-2 virus and subsequently COVID-19 did suffer from. And so the predominant one you can see is the underlying respiratory illnesses, including asthma, but more predominantly chronic pulmonary diseases. And then children with diabetes, also quite significantly affected, when it was there. I'll just go back. Children with hypertension, some with HIV, and significantly also some children with malignancies were quite significantly affected. So it generally paints a picture that children really have been, relative to adults, minimally affected in this illness. But just to say that they're not completely void of risk. Prof. Vardas spoke about the multisystem inflammatory syndrome, which we have seen an increasing number of cases recently, and there have been some reports of an increased incidence of newly diagnosed type 1 diabetics, and all of these things just remain to be observed. But relatively small numbers of each of these things, given the scope of the pandemic, even in South Africa. Now moving on to the educational component of this. So the Western Cape Education Department released a statement when the schools were closed in July, just noting again that school isn't a constitutional right for children, and reminding us that it's important for a child's health, for their food security, for future earnings, as well as for their safety. So often when we're driving around in Johannesburg or wherever we are, I always ask myself the question when the children are on holiday, why do they really have to go to school? Because the traffic's so much better when they aren't. But they really do. And the reason is this. One is for the learning, the actual content of the curriculum. So we teach our children how to learn, and some of the facts actually stick and are relevant to their future careers. But also they learn the art of engaging and interacting with the people around them, their peers, their teachers. There's social and emotional learning that goes on at school, which differs to what you learn in your household. There's opportunities for play, and that promotes appropriate development. And they also learn things like routine and discipline. So it's not just about the facts and the knowledge. There's so much more to schooling than we know. Additional benefits is that caregivers can actually relax to a large extent when they know that their children are in a safe environment and are cared for by responsible teachers, which hasn't been the case while everybody's been in lockdown. There's also, and for many people, and this is not just in our low middle income country, but there've been reports across the world that with the meals that are provided by the schools, so a single meal a day is often the only meal that these children will get. And so there's definitely nutritional benefits to children attending school. So it's often said that a hungry child can't learn, but in a situation like this, it's actually highlighting that that this meal is essential actually for their nutrition and not just for their learning. So it comes to the point of speaking about what learning opportunities are available. So if we're deciding not to send our children to school, what learning opportunities are possible? So there's traditional schooling. So we send our children to an actual school building and they learn from their teachers in a classroom. The alternative is learning on the electronic platforms or media platforms like TVs and radios and all those sorts of things. But they actually require quite intense, firstly, technological support, which is not readily available to all people in South Africa. And also it requires adult supervision because you cannot rely on a child to supervise their own learning, or a majority of children, I suppose. And then there's the alternative of homeschooling, which requires a caregiver to be quite intensely involved and dedicated to that. So what are the benefits of actual schooling for children? Obviously, there's the academic benefits, there's the nutritional components, there's the protection that is afforded to the children by actually being in the school environment. We have social and emotional well-being, and their developmental needs can be met to a large extent. The risks of not allowing our children to go to school. Over the longer term, education is a critical determinant of health. So even for missing this, and for a lot of children who have missed half the school year to date, over the long term, that may well have significant impacts on their health later on. Not schooling puts immense strain on caregivers. So having children at home makes that one parent or somebody in the household actually has to supervise their learning, just make sure that they're not out in the streets and doing all sorts of things that they shouldn't be doing. It's a massive strain in that sense. And then we've seen a lot of instances where young children are left to care for their younger siblings, with a rise in the rate of injuries and trauma that's been experienced in many settings. To the extent that we've just a few minutes ago finished a South African pediatric webinar series on child protection and non-accidental injuries because of the rise in prevalence of injuries that have been seen recently because children are caring for themselves, they're left unattended. And this morning I saw a report in the WHO bulletin on the COVID response the COVID-19 response measures and the violence against children. So throughout the world, we've been noticing that this is becoming problematic. So that's to summarize, the South African Pediatric Association and the Pediatric Management Group, which collectively represent all of the pediatricians in the country, have since May been recommending that the school buildings be opened and that children be allowed to continue their traditional learning methods. This, despite the peak, despite all of the things that were going on, because of the risks associated with not doing that. So that, in association with appropriate risk mitigation strategies, as has been covered quite extensively previously, and there's always been a recommendation to protect those who are most at risk, the teachers as well as the learners. And we've spoken about the high-risk categories of learners who might be affected. Yeah. So the question is then, what do we need for this to become a reality? So my feeling is that we need a compassionate and logical approach. To date, it's been very emotive, and people are very scared. So teachers are scared, caregivers are scared, and the children themselves are very scared of what might happen if they contract this virus. But it's been quite clearly shown that attending school is really not going to harm the children, and there is going to be massive benefit. We need realistic and holistic discussions on the risks and benefits of schooling. And as we've gone through, if people actually understand that the risk of disease to children is very, very low, and the benefits that they can accrue from actually going to school are great, they might feel more comforted. Where possible, we do need to individualize the approach for each family unit, and that's not necessarily possible on a large scale, but where we can, we have done lots of counseling for individual family units and decided that it may be appropriate for you to delay your return to school, or it's actually safe for you to go back. And that given all of the risk factors and the considerations of the contents of the household. And then, as pediatricians, we'll always say this, but it should always be in the best interest of the children. And that's not necessarily something that we've seen coming through that strongly, in my personal opinion, I can say. So that's pretty much what we have to say. Thank you very much for your time.
Thank you very much, Dr. Dennis, for that very insightful presentation. We would now like to open up our Q&A session, whereby we will be reading your questions that we've been receiving throughout this evening's session, and we will be posing the questions to our speakers. So if I could possibly start with Prof. Vardas. First question we've received is, do we anticipate a second wave like we see now in Europe? Prof. Vardas?
Thanks, Sharon. It's difficult to say. You know, we've already had level 2 where there's been a lot of mixing and a lot of people have been visiting and stuff, and we haven't really seen a peak in infections. So it's actually quite interesting. Most other countries have had second surges, so we shouldn't be resting too much on our laurels, and we should anticipate a second surge, but it hasn't occurred when we expected it to occur, which was immediately after the the level 2 lockdown. So we'll wait and see. Thank you.
Okay, and then Prof. Vardas, I think this is for you as well. Surely the gold standard is viral culture and not PCR. What is the diagnostic performance?
Viral culture is takes too long. So viral culture, which requires monolayers of cells, would take about 72 hours. So it really does not fit the bill for a diagnostic test or for a screening test. Certainly, if you were thinking as a gold standard comparator test, you might use viral culture, but really at this stage, no one's really using viral culture as a comparator test because of the difficulties with viral culture. So at the moment, the PCR is the gold standard.
Okay, and then our next question, what is the recommended protocol for testing?
I'm going to be hogging the questions. So the recommended protocol for testing currently is if you have a symptomatic patient for COVID, you need to do a PCR test. If you have a patient that may have had COVID in the past, 14 to 21 days ago, you can do an antibody test. So that's really the approach at this point in time. In certain clinical conditions, as mentioned in my talk, where you have a negative COVID test in a symptomatic individual, repeated negative COVID tests, and you still suspect that they're COVID, you can try and use antibodies. But again, it depends on the duration of from symptom onset. Antibodies will only come up 14 to 21 days after symptom onset.
Thank you, Prof. Vardas. And then I think this is our last question. What about testing after an infection? I think that's for you, Prof.
Sorry. Okay. So again, antibodies. So testing after an infection. I'm not sure what that means entirely. So is it testing for someone to go back to work, or is it testing for quarantine, or etc.? So it depends again how long after an infection you're talking about. These antibody tests are not helpful. They will be negative, and it will be a false negative if they're used too early. So we would only recommend testing if it's about 2 weeks after the infection.
Thank you, Prof. Vardas. On behalf of Lancet Laboratories, I would like to thank all participants for joining us this evening. Oh, sorry, Prof, we just got one last question. Can you take it before we close?
Me, Sharon?
Yes, sorry, Prof.
Okay.
It's regarding the cost of antibody tests. It just came through. Sorry.
So the antibody tests at the moment are 230 Rand. These are first generation tests, and we're hoping things will change in the future. But the current antibody testing is 230 Rand at most of the private labs.
Okay, thank you, Prof. Vardas. On behalf of Lancet Laboratories, we'd like to thank all participants for joining us this evening. Thank you for your participation. Thank you for engaging and interacting with us. We'd like to just reiterate that we will be sharing the link to the CPD multiple questions via email. We will also be sharing a recording of the talk via email with all participants and also those who registered but couldn't join us this evening. Thank you very much. Have a good evening. Goodbye.